All right, we're about to get into a section now where we look at how emergency first responders would assess individuals, and we're going to look at that including professional first responders such as BC Ambulance and emergency room personnel, as well as RCMP. But we're also going to look at what you as a first aider can do. So we're going to build on what we've learned about that secondary survey. One of the best resources for this is the Emergency Mental Health Education Manual, and it's printed by the Mental Health Evaluation and Community Consultation Unit. And like so many of the publications we're using in this course, you can readily access it through the Center for Applied Research in Mental Health and Addictions through SFU. And this is the link to their website. You can see that there are a significant number of books, reports, and resources, as well as journal articles here. And I think if you wanted to go to one place and make a quick stop and find a fantastic set of resources, this would be the place to go. The particular resource, and I've just sort of shortened it up here rather than scrolling through all of these, that we're going to go to is this one. And I will put this link onto the Moodle platform. This is the Emergency Mental Health Education Manual, and you can see that it is 178 pages of very rich information. So it talks about how to look at violent patients, suicidal patients, people going through psychological trauma, people with personality disorders, as well as substance-related disorders, and people who are, here we go, confused or demented older patients. So really a valuable resource. Here's another resource that I would like to connect you to. Again, the link to this is available through the Karma website, but I'll also put this specific link here. It will take you, when you go to Karma, to this particular one. This is a 206-page document, so again, it's probably best to access it, and you can save it to your desktop whenever you go there. It's a PDF type file. And this is the Guide to the Mental Health Act, and we'll be using that quite a lot as well. In fact, the addenda from this are quite useful, including the triage guidelines used by the RCMP and other police departments. So this is a very, very valuable resource, along with so much else that's on that Karma website. One of the things that we want to look at is how the multi-axial classification system or assessment system is used by emergency room personnel to get essentially a whole person picture of a person that comes into the emergency ward or observation unit. This, as you recall, is a system that includes 5 different axes or sort of tiers to look at the individual and think about not just their mental disorder but other major factors that might be playing a role in their diagnosis as well. And these other factors can play a significant role in determining what psychosocial supports a person might need as opposed to just what medical supports. For example, if you work with a social worker, these pieces of information will help significantly in terms of that social worker transitioning a person onto other types of care, including back into their family home or a community home. So the first axis is the mental disorders axis, and this is the one we would expect to see here. This is where the particular diagnoses or apparent diagnoses are listed by the physician and clinicians. The mental health disorder might be an apparent disorder at this point because in many cases the disorders require a longer observation period to have a concrete diagnosis. So this might be a provisional diagnosis. But this is the line where we would see the sorts of things that are what we call presenting problems, the very reasons why a person would be in front of us or come to us for service. So this is where we might see schizophrenia or psychosis of other shapes. It might be a drug or alcohol related disorder. It might be anxiety disorder, a mood disorder such as bipolar disorder, or major depression. It might be an autistic spectrum disorder, just to name some of the things that we might see in this category. And again, a reminder that people might have more than one diagnosis put on this line, and the clinician sometimes has to make the judgment call of writing down which one they think is the primary condition, the dominant condition, and perhaps in some cases try to determine whether the other conditions are caused by the primary condition, or that's what we mean by primary. Axis 2 is somewhat unique because it is isolated just for mental retardation, which in Canada we often refer to as intellectual disability or developmental disability. but in the DSM-4 and likely in the DSM-5 it will be still known as mental retardation. And personality disorders. So in other words, quite a few people will come in the door and never have anything written down on Axis 2. Why is Axis 2 set aside? What is the distinction between these disorders and the other mental disorders that we would see on Axis 1? Well, in a nutshell, both of these have in common the idea that they are considered to be pervasive conditions that overlay everything else that's going on in the person's life. And that would include the diagnostic process and the treatment process. These conditions make it somewhat more difficult for the clinician to understand what's going on with that individual, and they have to adjust in many cases the sort of interventions that they'll do because of these conditions. The other thing about them is that not only are they pervasive, but they're typically permanent. They're lifelong conditions. And rather than us trying to cure a person, we're often using that habilitative or supportive model, adjustment model that we talked about earlier. So a quick review that mental retardation is the clinical term for a person who has an IQ below 70 and has had their onset before the age of 18. And again, it's considered to be a developmentally permanent condition, and because it occurs so early in a person's life, it affects a lot of different areas, including socialization, learning and cognition, and communication. And many people, in fact, with mental retardation will have their intellectual disability as a result of a syndrome, a genetic condition, for example, or fetal alcohol syndrome. And those syndrome simply means that a person may have a constellation of commonly occurring symptoms, including symptoms that are mental health related, such as depression, or that may be physiological or physical. So people, for example, with Down syndrome have all of those things. They have the intellectual disability that comes along with the term mental retardation. They also have a higher propensity for a mental illness, in this case Alzheimer's disorder, especially with early onset, and a number of physical conditions, including heart defects, spinal defects, constant ear infections, eye problems, a higher propensity, for example, for cataracts, and on and on and on. So when we talk about mental retardation, in some cases the root cause of that intellectual disability is a larger syndrome, and it can mean both health and psychological implications. Personality disorders are a little bit harder for us to explain. There are, depending on who you look at, 10 or 11 personality disorders, and they are classified largely in 3 simple clusters. But perhaps the easiest way for us to kind of get a handle on personality disorders is by looking at a couple of other resources, and I will put these links up for you to look at as well. But let's take a quick look at them right now. All right, here's our first source. This is This is the Center for Addiction and Mental Health. And interestingly, depending on which resource you're looking at, you may see that there are 10 personality disorders, and that's typically the way that I have been trained. And in some cases, there is an 11th one that's identified. And so you may look, for example, at the Canadian Mental Health Association, and they have talked about 11 on their website. But again, it's a credible source. Here is the source for the for the Center for Addiction and Mental Health, and I like their definition. Personality is the synthesis of behaviors, cognitions, and emotions that makes each person unique. Despite this uniqueness, both healthy personality and personality disorder have defined patterns. Although our personalities allow others to predict and anticipate our responses to situation, a person with a healthy personality demonstrates a range of coping responses and styles when placed in a stressful situation. A disordered personality does not have this kind of adaptability and flexibility. The lack of adaptability and the limited repertoire of coping responses can result in distress for the person and for those around him or her. And I have to tell you, in my mind, that is the best definition I have seen for personality disorders. When I think of personality disorders, I think of distortions in personality. I think of people having a limited toolkit or always going to the same toolkit over and over and over again in terms of their social interactions and their ways of responding to stress or even to perceiving stress. And personality disorders are, we believe, socialized. We believe that most people get their personality disorders by the way that they're raised, which is why, again, they're something we consider typically to be permanent and pervasive. Here are the signs and symptoms in summary. The 10 personality disorders, as I said, are characterized into 3 clusters. Cluster A are basically people who are feeling paranoid, distrustful, and suspicious. These are people that would detach from society. Often we would describe them as eccentric or odd, or are just not able to fit in well. Cluster B are the impulsive personality disorders, where people often have impulse control issues, and they can be very, very challenging to deal with because their personalities often go to extremes. So borderline personality disorder is perhaps the most common one in my opinion, and yet one of the more difficult to describe. So we're going to come back to it. Narcissistic personality disorder is a person who sort of thinks me first. They really are focused on themselves. Histrionic personality disorder, a very strong emotional response, often out of context with what's going on around a person. And antisocial personality disorders are people who we would basically describe as often having difficulty fitting in with society. They're kind of rebellious. Sometimes they're what we call sociopathic, and sometimes don't seem to be able to relate to the social values of others. So all of these cluster B are characterized by having difficulty controlling emotions, fears, desires, and anger. Let's go back to that person with borderline personality disorder, because they are perhaps one of the most challenging individuals to support. And you will see this almost all of the time. Borderline personality disorder isolated from all of the other 10 or 11. And I would strongly encourage you to read this. And as you read it, I'm sure that you will start to recognize a number of people in your life who have some of these features. So people with BPD tend to have very strong emotional shifts, and they will shift from one strong sort of loving, seductive, very unconditional support for you type of emotion in one moment to a very dramatic, damning, condemning approach, and it sometimes is related to very small and very hard to interpret changes. So some of the things that we'll see with people with BPD: intense but short-lived bouts of anger, depression, or anxiety, emptiness associated with loneliness and neediness, paranoid thoughts, and dissociative states in which the mind or psyche shuts off painful thoughts or feelings. I'm going to pause here for a moment and just say this is why we call it borderline personality disorder. The borderline refers to the idea that the person is on the border between being psychotic, in other words, having altered perceptions of reality, and being neurotic, which means having highly distorted views of the world, highly distorted feelings, highly distorted behaviors. The self-image of the person can change depending on whom the person is with at that time, and it can be very difficult for that person to sort of live independently. In fact, as you work more and more with people with borderline personality disorders, you might see that they sometimes have some of the threads of the other cluster B disorders, such as histrionics, narcissism, and in some cases even antisocial aspects of their personality. This person can be very impulsive and can in fact engage in suicidal or non-suicidal self-injury. So the person may cut, burn, or they may engage in suicide, often in a more dramatic way, a more outward way than the person who, for example, has got major depression. An intense fear of being alone or of being abandoned, and you'll see this similar to one of our cluster C conditions, which is dependent personality disorder. Impulsive and emotionally volatile behaviors that may lead to the very abandonment that the person fears. In other words, self-fulfilling prophecies. And again, that person can be very similar to the histrionic individual. And volatile and stormy interpersonal relationships. These people can be very difficult to stay connected to, because in one moment they absolutely love you, and the next moment, for reasons which can sometimes be very difficult to interpret, they can reject you. Let's go back and look at cluster C. Cluster C are anxious personality disorders such as obsessive compulsive disorder. This is a person who hasn't quite reached the criteria of obsessive compulsive disorder. They have obsessive compulsive personality disorder. Dependent personality disorder is what many people refer to as codependency, people who are very fearful of being alone and who often define themselves by being with other individuals and sometimes make the choices to be with people who are very unhealthy for them, often due to chronically low self-esteem. And avoidant personality disorders are disorders where people have essentially chronic shyness. So these are characterized by people experiencing compulsions and anxiety. And anxiety and compulsions go hand in hand. Compulsions are often a way that people manage anxiety. So people with personality disorders, as it says here, are at risk for self-harming behaviors such as cutting or self-mutilation, or even threats, or even acting out on suicidal threats. They also, most importantly, may have very difficult time staying related to other people, which makes it very difficult sometimes to provide them support, both as an informal caregiver or as a clinical caregiver. The last link I want to show you is an excerpt, and again I'll put this link up on the web, on the Moodle platform, and these are a comparative description of what the DSM-4 said about some of the disorders and what the DSM-5 is going to say. These revisions were made in 2011 and are likely to be published in May 2013. The APA, the writer of the DSM, has put out many of these sorts of documents for public consumption and feedback. So it's very likely that these particular revisions are going to last, and we won't go through all of them right now, but you can see that they look at the general criteria, first of all, and you can see that it is simplified compared to where it was in the past. And what I like about this is that really when you look at the first three conditions, you really can see that it summarizes nicely. These are personality disorders in general. The person has significant impairments in self-identity or self-direction and interpersonal functioning, particularly around things like being empathic to others or intimate with others. One or more pathological personality trait domains or trait facets. Pathological means it's a trait built right into the individual's way of thinking and being. It's not a transient condition, and it affects our whole way of thinking. And it says here in trait C, or in condition C, that they're stable and they are impairments that affect the personal functioning. So again, they are not just transient interactions with one individual. They happen repeatedly in the person's life, and they tend to stay in that person's life. So this is a really good definition as well of personality disorders. And I'm not going to go on to this, but you can see that antisocial personality disorder, avoidant personality disorder, borderline personality disorder, narcissistic personality disorder, obsessive compulsive personality disorder, schizotypal personality disorder, and what they used to call personality disorder not otherwise specified is now got a new name, personality disorder trait specified, where now a clinician can simply say that an individual's diagnosis is specifically connected to one of these particular traits. And this is considered to be a sort of a new way of diagnosing. So this is really worth reading, and I got to tell you that myself, I will have to read it and study it to make some adjustments as we move into the new DSM. I strongly encourage you not only to look at these particular resources and distribute them amongst people in your team, but just to simply look up personality disorders more. Because as I said to you, when we look at Axis 2, many people will have no diagnosis. By the same token, I think it's safe to say that there are a number of people walking around out there who have most likely got a personality disorder that is undiagnosed. And even if the person isn't diagnosed, for you as perhaps a lay intervener, recognizing some of those considerations might affect how you go about getting that person support. Really being more attentive to the details and cautious in your communication, for example, or seeking support from others who can help you. In fact, that's one of the main points we want to make about people who have access to diagnoses, is that it means that we're likely to need to take a multidisciplinary or team-based approach, and we also are likely to need to really orient lay people like families or community health, mental health, social service workers who may not have the same amount of clinical education as a physician or even somebody working as an EMT might have. And so it can be important for us to either orient those people in clear ways to the interventions we support, but also to set them up or connect them with resources. And it's also important for us to learn from them in terms of what works with those particular individuals because they've often been long-term supporters. Let's take a look at Axis 3 for a moment. Axis 3 is identified specifically for physical health conditions. And these physical health conditions are particularly those which might have an implication in terms of the person's mental health. For example, if a person is diabetic and they are going through extremes of hypo and hyperglycemia, that particular physical condition will automatically have an impact on a person's mood state. And so dealing with that issue is essential in terms of helping a person with something like bipolar disorder or another mood disorder to get stable. And so diabetes is an example of that. Kidney function is another example of that. And heart disease and depression often go hand in hand as well, just to name 3 conditions. So getting a clear physical history from a person is extraordinarily important in terms of understanding how to help them with a mental health disorder, and making sure that we don't accidentally do things in terms of our treatment that can make things worse. Another one that we might think of, by the way, is our thyroid function. The thyroid function is, again, very closely tied to a person's energy level, their metabolism, their ability to process the medications they might receive. Axis 4 includes psychosocial factors. So here we're talking about things like the person's relationships to family, friends, spouses, or children, to their housing, to their employment stability, to their overall life stability. And if they're going through major flux in their life, such as grieving or through relational breakdown, these things can have an overwhelming effect, and a person who might otherwise normally have stable mental health might decompensate during these periods. And what they might need more than more medication is either some respite from psychosocial factors or some psychosocial intervention, such as counseling or assistance getting, for example, income assistance or housing assistance. And again, if we don't do that, go back to what we learned about Maslow in the previous module. If we don't help that individual to meet their physiological and safety and security needs, the chances of us having a lasting or even sometimes a short-term positive impact on their mental health are significantly diminished. Axis 5 is not terribly important to most of us, but I can tell you what it is to help you understand it. It's the last of the axes, and what it simply is a number, a score. And the score is called the Global Assessment of Functioning, or GAF scale. And it's important because what happens is that the clinician applies an overlay of questions and analysis to determine what the person's current score is on a scale of 1 to 100, or 0 to 100 to be more accurate. A state of 100 would be transcendent mental health. Most of us are lucky to be walking around between 75 and 85. 85 would be a really good day. People who are down in that 30 to 20 range are probably imminently suicidal. And people who are at 0, that number is specifically identified for folks we just don't have enough information about. So 0 doesn't mean the person's really low, it means we just don't have enough information about that individual. And the global assessment of functioning is very similar to something we learned in our secondary survey. It must be done on more than one occasion, and hopefully by the same clinician applying the same diagnostic assessment tool, because it's really about evaluating whether a person is progressing, regressing, or staying the same. It's a way of evaluating whether or not interventions are working and adjusting if not. So the global assessment of functioning is really sort of like a temperature check. It's the equivalent of giving a thermometer to somebody who's got a fever. So this is the multi-axial assessment system used by emergency room personnel. And you can see how some of the things that you would collect in your data collection or your assessment of the situation will help those people to make good decisions. Particularly be prepared to come in and give good history around number 3 and number 4. And the more conversant you are in number 1 and 2, the happier you're going to be and your client is going to be as well. Now, in your journal, note the following. What psychosocial factors might be important in assessing a client struggling with a mental health crisis? I've just talked about a few of them, but I'd like to see if you can go beyond that and think about psychosocial factors that are important to you and that might impact your mental health. And feel free to list some of the ones that I've just spoken of. Compare your answers with a partner or with other journal entries. And as I said, this is a 60-second journal entry, so this is a quick brainstorm.